Good afternoon, and welcome to this webinar, which is hosted by ESPGHAN and by the Special Interest Group on Celiac Disease. My name is Kjetil Størdal, and I'm the chair of this group at the moment. And I'm very happy to invite all of you to this hopefully lively discussion. And if you have questions and comments during this session, you are not able to use your microphones, but we will moderate discussion through submitted questions and comments in the Q&A box or in the chat box, as you like. And after the first two presentations, we will try to have a discussion between the two speakers and by the questions raised by you. So first, I would like to welcome Maria Scherman. She is from my neighbor country in Sweden, works at the Lund University and Skåne University Hospital as a pediatric gastroenterologist and a PhD researcher. And she will present the pros in a debate on population screening for celiac disease. So please, Maria, you can share your presentation and your thoughts.
Okay, thank you, Kjetil, and thank you for inviting me to this webinar. Can you see my slides?
Yes.
Very good, and you can hear me as well?
Yep.
Very good. So, as Kjetil said, I am a pediatrician, and I'm also a PhD student in Lund University in a project about screening for autoimmune diseases. And therefore, I was invited to speak today about the factors speaking in favor of population screening for celiac disease. Let's see. But before talking about celiac disease in particular, I would like to start about saying a few words about screening in general. There are two main purposes of screening. The first is to reduce morbidity and mortality of a certain condition by identifying individuals with the condition, but with mild or even no symptoms, for early initiation of treatment and to prevent long-term complications. The second purpose is to reduce the incidence of a certain condition by identifying healthy individuals who are at risk of developing the disease for intervention and possible prevention of progression to the clinical disease. And as you all know, to date, there is no way to prevent celiac disease other than, of course, avoiding gluten from birth and onward. But the only way to find another preventative measure is to conduct research in at-risk individuals identified through screening programs. And this type of research has been conducted in another type of autoimmune disease, namely type 1 diabetes. And in recent years, there has been a big breakthrough in prevention of type 1 diabetes. A couple of years ago, it was shown that a single course of the drug teplizumab, an anti-CD3 monoclonal antibody, given to at-risk individuals could delay the progression to clinical diabetes for a median of 2 years compared to placebo. And this, of course, has given a spark to the debate on screening for type 1 diabetes, as the only way to identify these individuals is through screening programs. And as type 1 diabetes and celiac disease share the same HLA risk genotypes, and the two diseases often overlap in the same individual or in individuals of the same family, a joint screening for the two diseases could be an alternative to maximize health benefits and cost effectiveness of screening programs. And in fact, in 2023, Italy was the first country to approve a law to implement nationwide screening for type 1 diabetes and celiac disease in children aged 1 to 17 years.
Maria, would you mind just removing the box, the reminder? Because
this little box,
yeah.
Of course.
Thank you.
There, can you see the full screen now? So before a joint screening for multiple autoimmune diseases can be discussed, it is important that each disease on its own fulfill the Wilson and Jungner criteria for screening. These criteria were published by the World Health Organization in 1968 and state 10 principles that should be used to assess whether a condition is suitable for screening or not. In this first part of the webinar, I will talk about the criteria that could be considered met for celiac disease. And in the second part of the webinar, Laura Kivelä will talk about the criteria that are still under debate. So the first principle states that the condition should be an important health problem. Celiac disease is a chronic T-cell mediated autoimmune disease triggered by the ingestion of gluten, leading to intestinal inflammation and villus atrophy. And the classical manifestations are malabsorption and gastrointestinal symptoms. However, the long-term consequences of celiac disease extends way beyond the gastrointestinal tract. Well-known complications, mainly seen in adults, are osteoporosis, refractory celiac disease, and certain malignancies. But there are also neurological, psychiatric, and infertility-related complications that have been associated with celiac disease. Furthermore, celiac disease is one of the most prevalent autoimmune diseases affecting both children and adults of all ages. The reported global prevalence of biopsy-confirmed celiac disease is around 0.7%. However, in screening studies, the reported prevalence is higher, around 1%. But in some regions, such as the Scandinavian countries where we live, the prevalence approaches 2 or even 3% in children and adolescents. And one of the main arguments for screening for celiac disease is the underdiagnosis. Celiac disease has a high prevalence, but also a high proportion of undetected cases, referred to as the celiac iceberg. In 2 recent screening studies, it was shown that 60% of children and 75% of adults with celiac disease would have been missed without a screening approach. To increase the detection rate, screening of risk groups is recommended. However, limiting screening to risk groups, such as those with genetic risk, first-degree relatives of patients with celiac disease, or individuals with associated conditions, such as type 1 diabetes, thyroid disease, Down syndrome, or Turner syndrome, will still be insufficient to detect the majority of cases. For example, in a screening study that we conducted here in Sweden in more than 2,000 school children, we saw a prevalence of 1.1% of undetected disease, and the majority of these children did not have a first-degree relative with celiac disease. And the reason for this large number of undetected cases is probably due to the wide range of presentations of celiac disease. We have the classic symptoms of malabsorption, such as diarrhea, weight loss, and growth retardation. And then we have the non-specific gastrointestinal symptoms, such as abdominal pain, gasiness, constipation. But then we also have the many extra-intestinal manifestations and complications mentioned before, such as iron deficiency, short stature, delayed puberty, hepatitis, infertility, osteoporosis, and neurological symptoms, etc. And then we have the challenging asymptomatic group. This complexity of the presentations often result in diagnostic delays, in some patients up to 10 years or more. And in a recent study, it was shown that a longer delay in diagnosis was associated with lower height for age, lower hemoglobin levels, higher TTGA titers, and higher severity of intestinal abnormalities. So one of the main questions in the debate of screening for celiac disease is whether or not the asymptomatic cases benefit from a gluten-free diet. And many studies suggest that they do. And more importantly, many of the so-called asymptomatic cases are not always truly asymptomatic. One study showed that screening-detected children had lower mean weight, height, and BMI compared to seronegative individuals. Another study showed that screening-detected children had reduced bone mass density, lower levels of vitamin D3, higher levels of PTH, and signs of systemic inflammation compared to controls and to children with celiac disease on a gluten-free diet. And a third study showed that iron deficiency was common at diagnosis of screening-detected celiac disease, but normalized after initiation of a gluten-free diet. On the same theme, one study showed that 50% of the children with no apparent reported symptoms at diagnosis actually reported alleviation of symptoms after the gluten-free diet, meaning that they actually had symptoms that they had not recognized before screening. Similarly, more than half of screen-detected children had symptoms unrecognized at diagnosis in another study. And that same study also showed that antibody levels, the severity of histologic damage, and the response to treatment did not differ between the screen-detected and those detected on a clinical basis. And in adults with screen-detected celiac disease, gluten-free diet resulted in significant improvements in overall gastrointestinal symptoms and health-related quality of life. And taken together, this indicates that even reportedly asymptomatic patients should be treated as patients and put on a gluten-free diet. And speaking of diet, it leads us to talk about the second Wilson and Jungner principle, that there should be an accepted treatment for patients with recognized disease. As the disease itself is triggered by gluten, a gluten-free diet leads to healing of the intestinal mucosa and decrease in antibody titers. However, this only happens if the patients adhere to the diet, and there has been a concern that the compliance would be worse in asymptomatic individuals. But in a large review study, it was shown that the majority of screen-detected children had an excellent adherence to the gluten-free diet. There have also been concerns that there would be negative psychosocial effects of the restrictive lifelong diet. But in one study, the health-related quality of life improved, of course, in symptomatic children after initiation of gluten-free diet. But in asymptomatic children, the diet did not lead to a reduction of the health-related quality of life. And another study showed that there were no significant differences between the screen-detected and symptom-detected children regarding the benefits of gluten-free diet in daily life, the child's attitude towards the diagnosis, the parents' satisfaction with the diagnosis, which was actually very high in this study. Moving on to the fourth principle, that there should be a recognizable latent or early symptomatic phase. Antibodies associated with celiac disease, for example, autoantibodies against tissue transglutaminase, endomysium antibodies, or deamidated gliadin peptide, can be measured in the blood months or even years before the clinical debut, and can thereby predict individuals that are at risk of progressing to disease. Some individuals detected at screening will already be asymptomatic or have mild symptoms, whilst others will be found to have what is called potential celiac disease. And this is an intermediate state of patients who are at risk of developing celiac disease, but do not currently meet the histological criteria for diagnosis, meaning they are seropositive, but they have a normal duodenal mucosa. In a recent large systematic review of more than 1,000 patients with potential celiac disease on a gluten-containing diet, who were followed for between 5 months and up to 13 years, about a third of those patients developed villus atrophy during follow-up. And this is also the group that could be eligible for potential preventative measures in the future. According to the fifth principle, there should be a suitable test or examination to detect individuals with disease or at risk of developing disease. An ideal test would perfectly separate those who do not have the condition from those who do, or those who are at risk of developing it, meaning a test with both high sensitivity and high specificity. But regardless of which test is chosen, there will always be an overlap of the two. In the last decades, multiple assays for different types of autoantibodies associated with celiac disease have been proposed and tested. And in the latest ESPGHAN guidelines on diagnosis of celiac disease, a meta-analysis is presented that showed that tissue transglutaminase IgA autoantibodies has high sensitivity without too much reduction in specificity, and therefore is recommended as the primary test for screening in children with suspected celiac disease. And this is also the most commonly used marker in screening studies. The sixth principle states that the test should be acceptable to the population. And as screening, celiac disease is usually screened for by serological testing. It's basically a blood test, and blood tests are generally well accepted by both children and adults. However, different approaches on how to collect those blood samples have been tried in different screening studies. For example, blood samples have been collected at selected research sites or at schools. Point of care tests have been collected when children are attending regular checkups in a way to integrate the screening into the regular healthcare system. And on the contrary, home capillary sampling has been tested to alleviate the burden on the healthcare system. Several of these studies are still ongoing, and in some of them, the acceptability of screening is also being evaluated. So, to summarize this first part of the webinar, the facts speaking in favor of screening for celiac disease is that it is an important health problem affecting more than 1% of the population, and the majority of cases will remain undetected without screening. The tissue transglutaminase IgA antibodies have high sensitivity and specificity for detecting cases and ruling out individuals who are not at risk. Furthermore, many of the asymptomatic cases detected are not truly asymptomatic, but actually have undetected signs of disease. The severity of histologic damage, the response to gluten-free diet, and the adherence to the diet is equally good among screen-detected and clinically detected, indicating that there is no reason to treat them differently. And most important, many of the numerous complications of celiac disease may be prevented by early detection and initiation of treatment. And that was all for me. Thank you.
Thanks a lot, Maria. Very clear and concise presentation. And we now allow Laura to share the screen and to talk about the cons of population screening for celiac disease. Laura is pediatrician in Helsinki at the Helsinki Children's Hospital, and where she's a resident in pediatrics and a researcher at the Tampere University, and defended her thesis 2018, I think it was, or even 17.
Yeah, 2018.
2018. So please listen to Laura, and then we, after that, we'll have a discussion.
Thank you, Kivelä, and thank you for the invitation to talk about the topic here today. So I will focus on the possible cons of population screening for celiac disease, and mainly I'm trying to highlight the open questions here and the questions where I think that we still need maybe more evidence. Maria already showed you the Wilson and Junger criteria for screening, and I'm also going to refer to those during my presentation. I also like this aspect where Sanabel Besson and colleagues have made for newborn screening, where they are looking different aspects of screening from clinical, diagnostic, therapeutic, program management point of view, and also ethical, legal, and social implications of screening. And I think that all of these aspects are quite relevant when we are talking about screening for celiac disease as well. And if we start with the clinical aspects, as Maria pointed out, celiac disease is very common. It's an important health problem, and it's significantly underdiagnosed in clinical practice. But we still have open questions about the progression of early stage to clinical disease. When we are talking about the diagnostics, we have available and accurate screening tests, but how much evidence we actually at the moment have about the acceptability of the screening for population. About the therapeutic point of view, we have accepted treatment, gluten-free diet, but have we actually enough evidence of the benefits for asymptomatic patients? And we also come back to the early stages of disease, and there we are maybe not that strong, we don't have that strong opinions on who should be treated. And when we are talking about the program management, do we actually have facilities to diagnose and treat all the patients? What is the cost effectiveness of screening? And how should we actually do the screening in practice? And we should also be sure that we are not overdiagnosing patients or causing too much stress and anxiety or economic burden. And I'm not going to focus on those questions Maria already told us about, so we know that celiac disease is important, there is accepted treatment and available accurate screening test. But during my presentation, I'm going to talk a bit about the natural history of celiac disease and the development of latent or early stage to clinical disease, and with this about also who should be treated. Then I'm going to say something about the facilities for the diagnosis and treatment, benefits versus harms for asymptomatic patients. And finally, I'm going to focus on the cost effectiveness and different screening strategies and what is the evidence on those. But when we talk about the natural history of celiac disease, we know that the patients need genetic risk factors associated especially with HLA so that they can even develop celiac disease. But then at the moment, we don't yet have possibilities to prevent the development of celiac disease. And the first signs of celiac disease are usually the autoantibodies, which can be measured from blood sample. But then again, we don't know who will actually progress from the seropositivity to actually end organ damage, duodenal villus atrophy in celiac disease. And finally, even when we have the diagnosis, we don't know who of the patients are at risk to develop those complications Maria described. And Maria already mentioned a bit potential celiac disease, which means that the patient has positive celiac disease antibodies, but patient doesn't have diagnostic villus atrophy in the small intestinal mucosal biopsies. And it has been estimated that potential celiac disease patients represent up to 20% of all celiac disease patients. And if we screen and if we suspect celiac disease with low threshold, it may increase the number. And we don't actually know that much about the clinical features and natural history of potential celiac disease. Some of the patients might be transiently seropositive, and like Maria said, maybe 1/3 of the patient will actually develop celiac disease on a gluten-containing diet. And what is really important question is that whether these patients are at risk to develop complications of untreated celiac disease. And at the moment, there is no consensus on whether gluten-free diet should be started when the seropositivity is found, and how follow-up should be organized. And these are really big questions if we are screening more and more patients, because then we should have some kind of protocols regarding the follow-up as well. And as we know, and as Maria presented, celiac disease is very common, and at the moment, most of the patients are undiagnosed. And if we all of a sudden can find all of these patients, I think that one relevant question is who will actually take care of these patients? Do we actually have the facilities for the diagnosis? And even if we can make the diagnosis, what happens after that? We have seen already that at the moment the follow-up is often suboptimal. These numbers are from our Finnish study, and we could see that few years after the diagnosis, most of the patients were followed up. But then when more time passes, then, and especially in the adulthood, only 25% were regularly seeing a doctor. And some of these patients were visiting healthcare because of some other conditions, and then celiac disease was taken care at the same time. So this is also important that those patients who are diagnosed, they also are followed up and get the support. Well, when we talk about asymptomatic patients, then I think that the main question is whether they actually benefit enough from the treatment compared to the possible burden of the diet. And Maria already described the different kind of permanent complications untreated celiac disease can cause, but I would like to highlight also the possible burden of gluten-free diet, because it's in a way very special treatment, because it's there all the time. It's very difficult to hide that you have celiac disease because many social situations are food related. And especially in some geographic areas, there might be poor availability and very high price of gluten-free products that may increase the risk of unbalanced diet. And all these things may affect the quality of life. But like Maria said, what is actually asymptomatic patient? Because many details count here, and defining asymptomatic, it is affected by the timing of asking about the symptoms, the method of measuring symptoms, whether patients know they have increased antibody levels, and whether they have already started the diet. Many things affect this. And like Maria said, these patients still can have clinical findings which they cannot feel, like poor growth, impaired bone health, laboratory abnormalities. And they are actually quite similar to those patients who feel the symptoms. But there is actually not that much evidence about the risk for these long-term complications in this group. And there I think that the bigger question is, in general, who is at risk to get these long-term complications if not treated. Well, what about the quality of life in screen-detected patients then? In this recent study from the USA with 1 year follow-up of screen-detected patients, we could see that the quality of life improved, especially when it was asked from the caregivers. But then one may ask whether this is some kind of honeymoon effect, whether 1 year follow-up is enough. And in our own study, where we followed up the patients median of 18 years. So these were patients who had been diagnosed in childhood and who were currently adults. We could see that asymptomatic patients were comparable to symptomatic screen-detected patients and clinically found patients, and also to non-celiac controls in most health-related quality of life aspects, but they did have more anxiety and decreased vitality. And we cannot be sure what is the reason for this, but at least this is something important to consider. And sometimes it might be also that the patients who have been found by screening are advised differently after the diagnosis. So it's also important that despite of the diagnostic methods, the patients are getting the same information about why is it important to follow the diet and what is the risk complications if not following the diet. But even if the patients are not that different, the presence or absence of symptoms at diagnosis could affect the motivation and also the adherence to a gluten-free diet. And regarding this topic, the results have been contradictory, and this could be because many other factors can affect adherence to the gluten-free diet as well. And maybe if the diet is more difficult to adhere in general, then the motivations could play a bigger role compared to if it's quite easy to adhere to the diet. And then we could ask whether it is justified to make the diagnosis if the treatment is not followed. And I think that this can also be country related, because in some of the countries it is probably easier to follow the diet compared to some other. But what is then best approach to actually find the patients? We know that celiac disease affects approximately 1 to 3% of population. If we are screening only those who belong to risk groups, first degree relatives or patients with some other autoimmune conditions, or if we are only looking for celiac disease in those patients who have some symptoms or clinical findings indicating possible celiac disease, we are not finding all of these patients. And that's why population level screening is the only way to actually find these patients. And one way is that we first screen for the genetics, and then we can focus on a bit smaller group of people. But what is the best strategy then? Well, Maria talked about the tissue transglutaminase antibodies, so it is usually used as the first line test together or without HLA screening before that. But we don't actually know that much about the best age and frequency of screening, because here we should try to optimize the yield at the same time when we are trying to make the diagnosis as early as possible to prevent the complications. And like Maria presented, there have also been ideas about screening for multiple conditions at the same time. And also there is the question, where and by whom should the screening be done, whether it should be home-based capillary sampling or healthcare integrated program. So this is also where we need more evidence. In our own study, which was just accepted for publication, we were looking at the optimal strategy from the cost effectiveness aspect, and we compared 272 unique strategies by modeling these. And we compared antibody screening versus first-line genetic screening combined with antibody screening. And we compared single-time screening at different ages from 3 to 18 years. And then we also combined screening at different ages twice. And in this analysis, we could see that the most cost-effective way was to screen once, approximately 11 years of age, or if repeated screening was preferred, the screening should have been done at 4 and 11 years of age. And in our analysis, HLA screening was still too expensive, but this is changing really fast because these prices are, especially for the genetic analysis, they are coming down. So this might be different in near future. But when we are talking about the cost effectiveness of screening in general, most recent and comprehensive health economic evaluations have supported their selected screening strategy from the cost effectiveness aspect. But it's really important to understand that it affects what kind of data you put in your analysis. It's defining what kind of answers you can get out. And one of the most important variables are the prevalence of celiac disease in the population and what happens without screening. What is the underdiagnosis and what is the diagnostic delay if screening is not done? Because that defines what kind of change can be done with screening. What is the quality of life of patients before and after screening? How do they adhere to a gluten-free diet? What are the costs of screening tests and the implementation of screening? What are the costs of healthcare utilization and absenteeism of patients from work? And what is the mortality effect of untreated condition? And currently, the challenge with modeling is also that we don't have that much evidence on complications and potential celiac disease to put into the models. And like it was said, many of these aspects are country-specific. But to summarize the open questions here, from the clinical aspect, we still need more evidence about the progression of early stage to clinical disease. From the diagnostic aspect, we should study about the acceptability of screening for the population. From the therapeutic aspect, we should focus on those patients who feel themselves asymptomatic or healthy, and we should have agreed policy on whom to treat. We should also have the facilities to manage the patients who are found and find out the best strategy for screening, which may differ between countries. And still we need also more outcome information, what happens after the diagnosis. Thank you.
Thank you, Laura, for presenting. I think we have had two very interesting introductions, and now we have time for a bit of debate. And first of all, I would ask the two speakers to oppose each other. So Maria, now you are allowed to challenge Laura on her statements, and after that, Laura will be the one to ask questions.
Okay. Well, thank you, Laura, for your presentation. I do agree with a lot of the things you are saying, and I do acknowledge that there are gaps in what we know, and there are gaps in the evidence proposing a general population screening at the moment. But the only way to learn more about this and find the evidence that we need is to perform screening studies. And I do think that the evidence pro screening at the moment is enough to at least propose screening studies to be made. I don't think we are doing too much harm to the individuals included in the screening studies, as the evidence is actually speaking for that we are doing a lot of good for these patients as well. And I think we need to answer the questions that you put forward, but we need the screenings to be able to answer them.
Yes, I completely agree with you, Maria, that the only way to actually get the answers for these questions is to do research. And I think that we just need to, in detail, define what are the open questions and where is the evidence gap, so that we are able to find the answers, and then after that make the decisions on the more like wide scale screening. And of course it is different to make research about screening compared to actually implement screening in the like lab, like in Italy, so that it is done everywhere. And as I've understood, also in Italy now they are piloting different kind of strategies to see what is the best way to go.
I think another problem is that with the criteria for diagnosis that we have today, like the ESPGHAN criteria, that actually lets us diagnose celiac disease in asymptomatic individuals, it will be hard to perform like randomized control studies saying that if we have identified an asymptomatic child, which we presume or know has all these histological damage, it will be hard to say or do a randomized control study to really test, do they have the same complications as the clinically detected? So we're in a phase where it will be hard to get some of that evidence that we would need.
Yeah, I think it's true that it's challenging to get some of the answers, but I'm also hoping that when we are having more and more advanced ways to model different kind of things and use, for example, artificial intelligence, then I hope that it would be possible to put together information we have from different sources and actually try to recognize different kind of phenotypes of celiac disease, which could then actually make it possible to predict the risk for complications as well. But we are not there yet, but I think that should be the future, so that it wouldn't be just one condition that this is celiac disease, but actually we would be able to differentiate different phenotypes there.
Yeah, I totally agree. And I think it's very important to have this kind of balanced approach and to really not focus too much on the numbers detected, but the health benefits of detecting those numbers, because that is a much tougher question, and really need to focus on that. That's my personal opinion. We have a question from Peter Gillett, and he's asking, Laura, for HLA in the screening strategy, what cost did you use for DQ typing in this model, which was advising against using genotyping, if I'm correct?
Yes, so we made different sensitivity analysis to find out the cost, where it would be cost effective to actually start with the HLA. And for single time antibody screening, it was approximately €4, and then for repeated screening, it was €16, if I remember correctly. But those were the prices that if we reduced the price so that it would become cost effectiveness, there was the limit for that. But I'm well aware that currently the prices, especially if you are screening for many samples at the same time with genetic analysis, then it's much cheaper than at the time when we made those analyses for our paper.
And I just on your comment there, Kjetil, that I totally agree. Like before, many studies, when you go through the evidence here, many studies are focusing mainly on how many do we find? What is the prevalence of undetected disease? But I think that's what's important up to us performing these screening studies now, is to actually follow up these patients and get as much evidence and as much information from these screening studies as possible on the health benefits and the harms and the cost effectiveness, of course.
Yeah,
So
yeah, I
please.
agree. And I think that it's also important that we are describing what are we doing now without screening, because that's very important as well, so that we know how the screening is actually changing things. So even if it's from the registries or more like retrospective in nature, I think that's also very relevant.
I think I can ask a question if there are no in the chat at the moment. Laura, I think that one thing that you basically not did touch upon is that there might be some social economic differences in who gets the diagnosis. And how would that be changed, or can we do better if we do population screening, or is it going to basically also serve the well-off population? What do you think?
Well, I think that is a really relevant aspect you pointed out, Kjetil. And at the moment, there is not that much evidence on that topic, and it depends on whether how the studies have been conducted, how the socioeconomic status affects. But it looks that those who have higher socioeconomic status, those are more likely to be diagnosed in clinical practice, because they have different health-seeking behavior. If their child has any kind of symptoms, they may have lower threshold to go to see a doctor, and maybe they have already found out that there might be this condition called celiac disease and so on. But there was also this very recent USA study which pointed out that even risk group screening, it's not better in that sense, because also in maybe 10% of children who should have been screened because they belong to the risk groups were actually screened. And also their socioeconomic status may affect. And then when we are planning different kind of population screening strategies, there is still a risk that we are actually not reaching all the people. There might be challenges with the language if people are not able to read about the information and so on. So I think that it's challenge with all the strategies, but at least if we would have this kind of strategy where we are providing the possibility for screening for everyone, I think that at least in theory that should decrease the socioeconomic differences.
We have two questions in the chat. One is from Daniel Agait. What is your experience from screening detected children? Are they happy or miserable from the diagnosis? Perhaps you have for sure some experiences, both of you. Is the diagnosis accepted, or is it a kind of...
I can start, since we conducted this general population screening in Sweden the last couple of years. And I can honestly say that sometimes you can question what we're doing when you get a list of 10 patients that you call, and all of them say that, well, my child is doing fine. How can you say this? How can you say that my child has a disease when he's doing perfectly fine and growing well? But then when you meet them after half a year or 6 months or a year, many of them are very satisfied. Because as I showed in the numbers, that is also my clinical experience, that they do actually have symptoms, or they had symptoms that they had not recognized. For example, and it's not only gastrointestinal symptoms, it can be mood swings, it can be trouble sleeping, or it could be weight stagnation. And they are most patients are very happy that we found this, and they are actually doing better after the diagnosis. And I think the most important thing is, maybe we cannot expect that that is true for everybody, but I think the most important thing is to show that we are not making these patients worse. We are not making them have a worse quality of life than before the diagnosis. And so far, not many studies have showed that that is the fact. They either have the same quality of life or actually improved.
Laura, do you want to comment?
Well, I could comment briefly. At the moment, we are not, at least yet, doing population screening in Finland. So most of the screen detected patients I'm meeting have been found because of risk group screening. And I think that it's also important to remember that different kind of factors also other than screening can affect that experience. Because if the patient already has a family member who has celiac disease, it may make a completely different situation. They might be already familiar with the diet, and then all the family can eat the same food and so on. And on the other hand, in some other risk groups, for example, patients who have type 1 diabetes, and then if they also get the diagnosis of celiac disease, it can be really challenging to combine those two. So I would just like to highlight that there are many other factors affecting this kind of experiences as well.
We also have a question about, I think you touched briefly on it, Laura. What would you advise in initial seropositivity without a positive biopsy, since there is no consensus on the topic? How do practitioners decide whether they should advise a gluten-free diet or not? Questions from Vilja Nikolova.
Well, I think this is a challenging topic, but it should be discussed with the family. And there you should look also other things than just the biopsy results, because if the child has symptoms, if they have anemia, if they have poor growth, if they are not doing well, I think that that kind of things would support for trying gluten-free diet. But then again, if the patient is asymptomatic, doing okay, or having maybe some mild gastrointestinal complaints, which might not be even associated with celiac disease, then I would say that it's safe to continue follow-up and consume normal amounts of gluten and see whether diagnostic changes develop. But I think that in these situations, it's really important to communicate with the families and explain for them what do we know about this and what are the options.
Next question, what is the suggested age when screening should be done? And would you suggest repeating screening in certain age groups based on the model that you have been submitting and which is going to be published soon?
Well, in our model, if we wanted to screen once, then it was at 11 years of age, and then screening twice was most cost effective when it was done at 4 and 11 years of age. But actually the age range was quite large, so it was maybe 5 years, around 11 years of age, and the same if you started screening at 4, 5, 6, and so on. Then if you waited at least 5 years before making the repeated screening, then it was cost effective. But actually this cost effectiveness analysis, it's just one point to look at this. And then I think it's also relevant to see again the whole picture. If you screen really early, you are able to find the patients before they develop the complications, but then again, you cannot find all the patients because some of them will develop celiac disease after the screening. But then again, if you screen really late, then there will be longer diagnostic delay for everyone. And also, I think that it's maybe not the best idea to screen teenagers because it's really difficult time to adapt to dietary changes. So I think that also here we have many aspects which are difficult to include this kind of model where we are looking at the costs and this kind of things.
Right. The final question from Ilma Korpona-Trabo is cost effectiveness calculation. How do you take into account the age in respect of preventable disorders, not just finding celiac disease and treat the symptoms, if any, but later consequences?
Yes, that's really good point, because we were not able to take that into account because we don't have that kind of evidence to put into the model. Maybe we have ideas about how it would affect if we find celiac disease at different age. How could we then, in theory, prevent different disorders? But with the currently available data, it wasn't possible to put that point into the model, even though I think that we all agree that it would be really relevant when we are talking about screening.
Thank you. I think we have had a good debate, but this is certainly not the end of this story. And I think that we should really evaluate the studies that are ongoing and coming out and see what is happening in the next few years about these studies and what is the findings. We have another webinar in 4 weeks from now, which is also hosted by the Special Interest Group on Celiac Disease. So you are more than welcome to join again, and you can again register on the ESPGHAN website for this webinar. So thanks to Laura and Maria for presenting and sharing their presentations, and thanks for all of you for this debate.
Thank you, Kjetil, for the invitation and for the nice discussion, Maria.
Yes, thank you to both and everybody who listened.
Bye-bye.
Bye.
Yes, bye-bye.